Hello, future doctors, and welcome. Today, we are going to tackle a topic that's, well, absolutely fundamental to your understanding of medicine, neoplasia. We're going to build a rock-solid foundation, starting with the tiny changes in a single cell and taking it all the way to how we, as clinicians, think about it and manage it. Honestly, getting this right is non-negotiable, so let's just dive right in.
So here's our roadmap for today. We'll kick things off with the absolute basics. What is neoplasia really? Then we're going to follow the story, the journey of a cell as it becomes malignant. After that, we'll crack the code on how these things are named, the language of pathology. And finally, we will clear up two of the most commonly confused but incredibly important clinical concepts, grade and stage.
Sound good?
Let's get started. All right, first things first. Let's lay the groundwork and get a really solid definition of what we're actually talking about when we say neoplasia. Okay, this definition looks really simple, but it is packed with meaning. The two words you have to lock into your brain are uncontrolled and monoclonal. Uncontrolled means these cells have completely stopped listening to the body's signals to stop growing. It's like a car with the accelerator jammed to the floor and no brakes. And monoclonal is just as important. It means this entire mass of cells, maybe millions of them, all came from one single ancestral cell that decided to go rogue. You know, it's a really common mistake to picture a tumor as just a big ball of cancer cells. But it's way more complex than that. It's an organized structure. You've got the parenchyma, those are the actual tumor cells, the bad guys. But they're clever. They can't survive on their own, so they trick the body into building them a life support system. That's the supporting stroma, a whole network of non-cancerous blood vessels and connective tissue. And this is a huge deal clinically, because a lot of modern cancer drugs actually work by targeting this support system to starve the tumor. So how does this process even start? Let's trace this story, the step-by-step biography of a tumor, if you will, starting from a perfectly normal, healthy cell all the way to a dangerous malignancy. We can really break this whole progression down into 5 distinct stages, starting from normal tissue. And truly understanding each step of this journey is the key to understanding all of cancer pathology. Let's break down each one. Okay, the very first warning sign is something we call dysplasia. If a pathologist looked at this tissue under a microscope, they'd see that the cells are starting to look weird. They've lost their nice, uniform shape, and the whole tissue architecture is disorganized. But here's the critical part. At this point, the change is often reversible. Think about the lungs of a smoker. If they quit, that dysplasia can actually go away. The body is basically sending up a red flag. Now things get more serious. We've progressed to carcinoma in situ. The dysplasia is now severe, it's irreversible, and it's taken over the full thickness of the epithelium. That analogy of the basement membrane being a fence is perfect here. The bad cells have completely filled the yard, right up to the property line. But, and this is the key, they are still contained. They haven't broken out yet. And this next step, invasive carcinoma, is the game changer. This is the single most critical event in this whole process. The tumor cells start producing enzymes like collagenases that literally dissolve that basement membrane fence. They've breached the barrier. And by doing that, they've gained access to the body's superhighways, the blood vessels and the lymphatics. The potential to spread is now unlocked. So once those cells are invasive, they can hop onto those highways and travel. This is metastasis. You can think of the tumor cells like seeds, traveling through the bloodstream or lymphatic system, looking for fertile soil in a distant organ, like the liver, the lungs, or the brain, where they can land and start a new colony. Okay, we've got the process down. Now let's learn how to speak the language. There's a really logical system for naming tumors, and it can tell you a ton about where it came from and how it's likely to behave. This is the first, most fundamental split in how we name malignant tumors. It all boils down to the tissue of origin. If a tumor comes from epithelial tissue, the stuff that forms linings, coverings, and glands, we call it a carcinoma. Just think C for covering. If it comes from mesenchymal tissue, that's the connective or supportive stuff like bone, muscle, and fat, we call it a sarcoma. Think S for supportive tissue. It's that simple. Now check out the pattern on this table. The suffix, the end of the word, is a massive clue. As a general rule, if you see oma by itself, it means it's a benign growth. A lymphoma is just a harmless fatty tumor. But when you add sarcoma or carcinoma to the root word, that signals it's malignant. So a benign lymphoma becomes a malignant liposarcoma. A benign smooth muscle tumor, a leiomyoma, becomes a malignant leiomyosarcoma. See that pattern? It's a really useful shortcut.
Okay, everyone, listen up. This next concept is probably one of the most high-yield topics in all of pathology and oncology. You will be tested on it, you will see it in practice constantly. So let's make sure we clearly distinguish between grade and stage. The absolute easiest way to keep this straight is to just ask two simple questions. For grade, the question is, how ugly do the cells look under the microscope? It's all about their appearance. Do they look a lot like normal cells, or are they a total mess? For stage, the question is totally different. How far has the tumor spread in the body? It's about location and size. So just remember, grade is looks, stage is spread. So how do we determine the stage? We use this brilliant and universal system called TNM. It's a really powerful tool. T stands for the primary tumor. We're looking at its size and how deeply it's invaded locally. N tells us if it's spread to any nearby lymph nodes. And M is the big one. It tells us if there is distant metastasis, those new colonies in faraway organs. And this brings us to the single most important clinical pearl of this entire talk. If you have to pick one thing that predicts a patient's outcome, it is always, always stage. So for example, a low-grade tumor, one where the cells look pretty normal, that has spread everywhere, giving it a high stage, has a much worse prognosis than a really ugly high-grade tumor that's still tiny and localized, giving it a low stage. Spread determines survival, period. This little pyramid shows you the hierarchy within the TNM system perfectly. While T and N are definitely important, the presence of M, distant metastasis, is the single most powerful prognostic factor. And why is that? Well, once a cancer has metastasized, it's not a local problem anymore. You can't just cut it out. It's become a systemic disease, and that completely changes the prognosis and how we have to treat it. All right, we have covered a ton of ground, from a single renegade cell all the way to the big clinical picture. So let's bring it all home and lock in the key takeaways that you absolutely have to know. Think of this table as your go-to cheat sheet. Seriously, if you can master these 5 core concepts, you're going to have a really strong and lasting understanding of neoplasia. Remember that basement membrane is the critical barrier. Carcinoma is epithelial, sarcoma is mesenchymal. Grade is what the cells look like, stage is where the tumor is. And when it comes to prognosis, stage is king. So to wrap everything up, I want to leave you with a question that kind of bridges what we learned today with the future of medicine. We know that tumor cells use specific enzymes to break through that basement membrane. So how could we use that knowledge? Could we maybe develop drugs that block those exact enzymes? Could we effectively build a new chemical fence to keep the tumor contained? This is how foundational science leads to real therapeutic innovation. By understanding the how, you can start to imagine the future of treatment.